the interest in this topic will keep you awake. I'm Vandana Gupta from VK Foundation, and it has been our endeavor to bring up topics of interest, not only for cancer patients, lay people, and this time maybe some of the doctors. So we thought, because there's so many medicines coming and how many things we are popping up, that talking about AMR would be a good idea. So warm welcome to Dr. Parikshit Prayag, who's our expert on transplant infectious diseases, and he's from Dinanath Mangeshkar Hospital, Pune. Welcome, doctor. We have Dr.
Thank you.
Lingraj Nayak, who's a hemato-oncologist at Tata Memorial Hospital in Mumbai. And we have Dr. Akanksha Chichare from the pediatric oncologist at ACTRAC in Kharghar in Mumbai. Welcome to all of you. And Dr. Sujata Lal, who's an assistant professor, Department of Microbiology, again from ACTRAC, and Dr. Naveen Khatri, the director of ACTRAC, who has very kindly given us the names of these very eminent personalities. And Dr. Khatri is an advisor on BCare board. So we are all working and hoping that it will be a very good, informative thing. So over to you, Dr. Prag, and all yours now.
Yes, thank you so much, Vandana ma'am, and good afternoon or good evening to everyone, wherever you're logging in from. So it's really a very good initiative, when we look at antimicrobial resistance, we have to, start from the basics, that what does antimicrobial resistance mean? We have all heard about this, I'm sure, in the media and in the press and on television, and more so in India. We have got a bad press because of antimicrobial resistance. I remember when I was training in the US, when we used to get a patient from India, at MD Anderson, there used to be a lot of panic surrounding this patient. This was almost looked upon as an alien, someone harboring resistant bugs or someone harboring super bugs. So this was not a pleasant situation to be in. And if you look at the numbers, then India leads the world in the consumption of antimicrobials. Or if you look at our antimicrobial resistance numbers, then those are pretty scary. So this is a very good initiative, and we need more of such platforms and initiatives to really create awareness. Because if you look at this battle, then it's a many-fold battle. I mean, you can't fight it just on one front. It is not a battle which can be fought only in the hospital. All of us need to be on the same platform at various levels. So right from the patient to the prescriber, to the microbiologist, to the hematologist, to the oncologist, to the infectious disease physician, everyone needs to be on the same page, and even patient education and awareness is really important. We have to question some of the practices that we have been following for decades, especially in our country. And every time an antimicrobial is prescribed, we have to ask ourselves, why are we taking this antibiotic? What is the bug that we are trying to cover? And so on. So I think it's a great platform, and I'm sure in the next 45 to 50 minutes, we'll try and decipher some of the basics and really see what this problem is, and if there are any solutions, what can one do at each level. Like I said, right from the patient to the clinician to someone who is in diagnostics, or someone who is in therapeutics, someone who is in research. From all our aspects, what can we do to sort of contribute to this, or contribute to the solutions towards this problem. So let me start with my microbiologist, Dr. Sujata. Dr. Sujata, quick, definitions, if I can use that term. A lot of our users would first like to know that what does the term antibiotic really mean? And before that, what are the different types of organisms? So what do we really mean by bacterial infections and viral infections? And what do we mean when we use the term antibiotic or an antimicrobial?
So yes, antibiotics, previously the word, it was derived that it was a drug or a chemical or a compound which is obtained from some, previously it was some organism through which this drug was obtained, like penicillin was obtained from Penicillium notatum. So the word has been derived from that, but now it is being used as a compound, a chemical, or any drug which kills or inhibits the growth of a microorganism. So for a layman, it's a germ. So a germ which when goes inside the body, replicates, it multiplies, it can cause an infection. So infection is killed by antibiotic to make it very simpler. An antibiotic kills an infection. But the thing is, infection can be caused by many kinds of germs. So germs, जिसको हम हिंदी में जंतु बोलते हैं, पेशेंट्स को एक सिंपल भाषा में बताने के लिए, parasite, there can be fungus, but the antibiotic per se is only for the bacteria. So it is going to kill only the bacteria or inhibit the growth of bacteria only. Bacteria, virus, fungi, protozoa, they are absolutely different kind of germs. अलग अलग तरह के germs है which once when they go inside the body, they grow, they multiply, वो multiply होकर पूरी बॉडी में इन्फेक्शन स्प्रेड करते हैं. सो इनके अलग अलग वेरिएंट्स हैं. जैसे अभी जो वायरस हमें पता है, द वायरस वी नो राइट नाउ, जिसकी वजह से द वायरस वर्ड हैज बिकम मच मोर इजियर टू टेक, इज द कोविड-19 वायरस. बट द बैक्टीरिया आर able to cause more fulminant and more spreading kind of infections as compared to the virus. So shall I describe the differences between bacteria and virus?
Yes, sure. In simple terms, if you can highlight.
Yes. In simple terms, bacteria is actually a living kind of a prototype organism, but virus, as per individually, it is not a living organism. Bacteria can replicate easily. Even आपको bacteria आपके सरफेस पर भी मिलेगा, आपके सॉइल में मिलेगा, आपकी स्किन पे भी बैक्टीरिया रहेगा. वायरसेस वो आपके ह्यूमन बॉडी के बिना दे कैन नॉट रेप्लिकेट. दे नीड अनदर ह्यूमन बॉडी, अनदर ह्यूमन cell to go inside and replicate. So bacteria basically it is a survivor even outside the human body, but viruses need some human body, a human cell to replicate. Plus viruses we cannot see even in the normal microscope. The size is absolutely exponentially smaller than those of the bacteria. Bacteria have a much bigger size as compared to the viruses, but as per the layman view, the diseases caused by bacteria are much more dangerous and fast spreading as compared to the viruses.
Yes, absolutely. So so as Dr. Sujata said, we have different types of infections. So when we talk of an infection, it can be because of bacteria, or it can be because of viruses, it can be because of fungal organisms, it can be because of parasites or worms, as we call them colloquially. So it's really important to understand the differences between these. And as she suggested, the term antimicrobials is a broad term. So when we talk of the term antimicrobials, you have antibacterial agents there, you have antiviral agents, you have antifungal agents, you have anti-parasitic agents. So Dr. Sujata, which resistance is really more concerning? As we all know, resistance is when we reach a stage wherein these agents no longer continue to work. So according to you, can we develop resistance, or can the organisms become resistant to all of these antibacterials, antivirals, antifungals? What would be more concerning?
So the resistance word, if I can tell to a layman, that the infection which was previously treatable, like वही drug पहले काम कर रहा था, but अभी वो the drug is not able to act on the organism. The simple infection becomes fatal if the resistance is developed. So resistance right now in Indian setting, we are seeing much more in case of antibiotic resistance. And bacteria also gram negative organisms. So this is a difference in the Western countries as compared to the India. Western countries have more resistance in gram positive spectrum, while we have multi-drug resistance gram negative straight up. So MDR strains of gram negative organisms are more seen in Indian subcontinent rather than the US and Europe, we can say.
Can you briefly tell our viewers gram positives and gram negatives?
So gram positive and negative, this is a kind of method to differentiate these germs, the bacteria. This is a kind of a laboratory method जिससे कि हम stain करके we can see two different kinds of bacteria. This is a differentiator to differentiate some bacteria based on their structure. जो उनके बॉडी में, बैक्टीरिया की बॉडी में कुछ ऐसा कंपाउंड है जो स्टेन लेता है और नहीं लेता. So based on that, we are giving the terms gram positive and negative. So the clinical implication is the drug lines for both these organisms are different. Gram positive we have Staphylococcus, Streptococcus. Gram negative we have E. coli, Klebsiella. So the main thing is the drug lines for both these organisms are different.
Right. So let me get my clinicians also on board. Lingaraj, great to have you. What according to you is, I mean, when you are seeing patients in the hematology oncology setup, like how is this resistance manifesting? So what do you really see on your rounds every day, and how much of a problem is it?
Thank you, Dr. Parikshit, for the question. So, antibiotic resistance, as nicely discussed by Dr. Sujata, that which is a major concern for bacterial infection as compared to viral or fungal infection. So, most common situations that we face in our day-to-day clinical practice is something like patients having fever, not responding to the regular antibiotics that we use commonly. In spite of giving higher generation of antibiotic, there is persistent fever, and say, for example, infections mostly in the lung, in the blood, and gradually, when these infections are not controlled timely, especially in patients who are immunocompromised or patients who are having cancer, these infections can lead to compromise in their saturation level, oxygen level, blood pressures, and following that, there will be dysfunction of organs like kidneys and livers, and gradually these patients land up in ICU. So this is the typical clinical course of patients who develop these resistant organisms, and subsequently that affects the overall results, and and it also compromises the delivery of cancer treatment as well. So these are basic problems that we see in our patients, specifically blood cancer patients.
Yes, thank you so much. We have with us Dr. Akanksha, who is a pediatric oncologist. Akanksha, again, lovely to have you. Would you say that this is a problem which is exclusive to the adult population? How much of a problem is this in your pediatric patients?
Yeah, thank you, Parikshit. So this is definitely not just limited to the adult population. This is the same kind of clinical scenario that we see with the children also who have cancer. So like Dr. Lingaraj has just pointed out and said that we are getting more and more patients who are newly getting diagnosed with cancer, and we see that a lot of them actually are already colonized with multi-drug resistant bacterial organisms when they come to us. So it is actually prevalent in the community. It's not just that we are seeing it in the children who are on treatment and immunocompromised only, but the ones who are coming to us upfront are also colonized a lot of times with multi-drug resistant organisms. And this is not definitely exclusive to any age group. We are seeing it all across. And as Lingaraj said, this is really complicates everything because it leads to longer hospital stays, more ICU admissions, and more morbidity, more children having problems than they should actually.
Yes, absolutely. So let me ask the same question to both of you again, Lingaraj and Akanksha. Let me start with you, Lingaraj. What is the magnitude of this problem according to you? Through your training and now in your practice, or you are now in an academic position. So through your trainings over the last 5 to 10 years and right now, how much has this changed in terms of magnitude? Is it a bigger problem right now, and how much of it are we facing? So out of the number of patients that, let's say you see 10 patients in the wards or you see 10 patients in the ICU, in how many of these would you encounter such problems?
Yeah, so I think that's a valid point, valid question, Dr. Parikshit, because so when I started my training, right from the days of MBBS, MD, and now DM, and then and consultant in an institute, so I have seen those phase where we have situations where patients used to respond to a first generation cephalosporin, in hospitalized patients, but now with increasing time, in a span of last 5 to 8 years. So I think the number or the magnitude of this antibiotic resistance has increased phenomenally. And if I have to give you a number in our routine clinical practice, when we have documented infection, wherever, be it blood, be it some abscess, be it some infection in the lung, where there is proven bug we have isolated, where the amount of resistance by various methods that we use, we see almost 70 to 80% of our bugs are resistant to multiple types of antibiotics, that is the multi-drug resistant organisms. So the magnitude problem is definitely very high, and I think it will be same across pediatric as well.
Yes, Akanksha, your thoughts?
No, I agree with Lingraj. So, over the last decade or so also, it is very apparent that, we rarely end up starting the first line antibiotics, which we used to say 8 or 10 years back. More and more patients, whether it is children or adults, are actually going on to very high-end antibiotics even at the beginning. So I think this problem is escalating to a huge extent. Yeah. Over the last 10 years, I think it's really become a big public problem.
Yes.
Yeah.
Lingaraj, was it something that was talked about when you were in medical school?
So yeah, so I think we had this lecture. We had lectures on antibiotic resistance, but now when in last couple of years, what we are learning is something new that we are never taught in our medical school. Like we are learning about newer kinds of resistance we have never taught earlier. So I think that is just it just says that in last couple of years, I think the type of resistance has increased significantly in last couple of years.
Akanksha, as someone who works in an academic setup, are we talking about this enough with our residents, fellows, trainees?
Yes, so I think antimicrobial resistance now is something which is in the forefront everywhere. It's not only in the academic institutes, definitely in the academic institutes. There's more and more sensitization which is happening amongst the residents and the fellows about how to avoid, how to prevent, how to decrease antimicrobial resistance. And worldwide, with WHO taking it up on such a big scale, it's a worldwide thing. But in academic institutes, there is more and more sensitization over the last couple of years about, like Lingaraj said, there were all these antimicrobial resistances, say 10 years back was more of a theoretical thing, maybe to some extent. But now we're learning about so many different classes of antimicrobial resistance and so many newer drugs to kind of battle that it's like a ever-changing landscape. Yeah.
So let me ask all three of you, Dr. Sujata, Lingaraj, as well as Akanksha, the same question. Are we talking about this enough as far as the common people are concerned? Now, we have a lot of outreach on COVID as far as common people are concerned. Everyone seems to be a COVID expert. WhatsApp groups are flooded with COVID knowledge. Are we talking about things like antimicrobial resistance enough in mainstream media? Now, we never have national debates on, or we very rarely have national debates on antimicrobial resistance, or the nation wants to know kind of debates that we have on politics. Do we have enough of it on antimicrobial resistance? And we seem to be talking about certain diseases far more in the media than certain other diseases. Your take on that, Dr. Sujata? How much are we? How much of it are we sort of penetrating into the masses?
So my views are, as a microbiologist, we are talking about this topic, I think, from the last 10 years. And this is the most important and the forefront topic for any microbiologist. But on the contrary, the impact which it has on the general population and the cases, the extent to which it has to be discussed among the general population is absolutely zero. The extent in which the microbiologists are discussing it is 100%, but the information which has to be generated and given to the general public and patients, how they can contribute to lowering the extent, is absolutely zero. Like as we are seeing in the COVID time, a simple illness like cough cold, they have generated massive tons of education through WhatsApp and all kinds of media, but no media anywhere has ever communicated this aspect of antimicrobial resistance, which is the impact is far greater than what we are seeing for the COVID thing. Because we are discussing it basically in our labs, in our conferences. There are conferences specifically for the antimicrobial resistance, how to handle it, but the situation can be handled at both the ends both at the caregiver side, doctor side, and also at the patient side also. The use of over-the-counter drugs, how they stop the medication in between, how they take medications without any prescription, all this is contributing equally to the development of resistance, but they are not even taught and they are not aware that this they don't have to do. So I think the information is practically zero at the user end. We are having all the information, but the bridge from the doctor to the patient is not there.
Lingara, your take on it? Would you like to see more on antimicrobial resistance than Uttar Pradesh elections in the newspapers?
Yeah. So I think no, rightly pointed out, Parikshit. So I think this is something which is never discussed. I would say discussed in national forums and meetings are also very less. I think we need special fields or special branch on this particular area because this is something which is going to be a problem in future as well. So I think one other thing is that about the as Dr. Sujata said at the user end, so I think all of us know, if you see the approach of the common public is about the use of antibiotics, and not use, I would say it's an abuse of antibiotics by common uh, people who are suffering from any kind of mild infections, and they are unhappy when they go to a doctor and the doctor do not prescribe an antibiotic. So I think that awareness is something which has to come in, and media can play a bigger role in this, where make people aware that you don't need an antibiotic for every infection, for everything rather, so that is something that has to come, and to be educated for the people by newspapers, by television media. So I think this is at both the ends, as you rightly said. It is you both as the user end, and they has to be aware well.
Absolutely, excellent. Akanksha, are we as doctors not doing enough to sort of make sure that the common public is also on board? I mean, we keep talking about antimicrobial resistance in meetings and in conferences or in gram-negative lectures, but at the end of the day, as Lingaraj pointed out, the end user also has to be educated. So are we guilty of not doing enough for public education, as a community?
No, yeah, I think, Parikshit, absolutely. The onus does to quite an extent lie with the medical community, because we are, like you rightly said, we are discussing this now more and more in our conferences and in our webinars and everything. But actually, on the ground, there is not much of information which is getting passed on to the general public. Even if you look at the cancer patients, right? Even the caregivers of the cancer patients that we have here, or the children who are with the parents and everything, we are giving them to some extent some information, but the general public is not really getting any information. It's not getting percolated down there, because I think we are definitely at fault. We are also not probably trying to, we haven't maybe probably made that kind of an effort. Something simple like you have these school health programs where even general pediatricians or physicians go for a general checkup in school. Even that kind of a forum would be a good forum to disseminate information to the college children and to the school children about all the hygiene practices and antibiotic use, and like Dr. Sujata said, taking the prescribed course of antibiotic, not taking antibiotics without prescriptions, not asking for medications when it is actually not required. So yeah, I think there is a lacunae from the medical community side as well, because until unless the general population gets sensitized, we cannot expect them to sort of learn all these things by themselves.
Absolutely. Dr. Sujata, let me come to the technical aspects a bit now. How does an organism really become resistant to antimicrobials?
So there are many ways that an organism previously treatable by a antibiotic later becomes untreatable by the same antibiotic. So if we start from the basic, we have seen the Darwin's theory of natural selection. So in a population of, if see 100 bugs are there and we give an antibiotic, the one which is able to survive will survive against the antibiotic as compared to the 99 others. So over a period, the one will multiply, and then there will be a population of all the resistant bugs which won't be killed by the same antibiotic. So technically, we have various mechanisms, like the organism can eject out the antibiotic. It cannot allow the antibiotic to penetrate and come inside. It develops certain coatings on itself that the antibiotic cannot come and kill uh, the organism. Sometimes it develops various mutants in certain circumstances. The mutants have the capability not to be killed by the antibiotic by not producing that metabolite which the antibiotic needs to act upon. So there are various mechanisms, but eventually the bug which has replicates every time, and the antibiotic is not able to kill the entire population of that resistant bug, basically.
So is it something which is concerning only in hospital bugs, or you would see this in the community as well?
It's prevalent both the places, community and hospital. But the thing is that we as doctors are focused in our labs, or as we see the patients. But I feel the community spread is far more in magnitude as compared to the hospital, because if we see at the population in a periphery, like who are not even aware of what antibiotic is, they just go to a the chemist and they ask for an over the counter drug, and antibiotics are prescribed like anything in peripheries. So in spite of knowing what they are taking, they are just abusing the drug, and sometimes they take it the antibiotic or for 1 or 2 days, even when the prescribed duration is for 5 days. And the patient has a normal saying that अभी ठीक लग रहा है तो इसके बाद क्यों लेना है. So that kind of mentality which has grown, it has to be communicated to the patient end, because the magnitude, as far as I can see, is 50%. 50% both from the hospital and community.
Let me come back to my clinicians, Lingaraj and Akanksha. I'll start with Lingaraj. Your take on the reasons why we have so much antimicrobial resistance, and would you say that we have more of it in India compared to the Western world? And if yes, what are some of the unique things that has sort of predisposed us to so much of antimicrobial resistance? Is it a nitrogenic problem? Your take on this?
Yeah, I think the burden is more in India as compared to West is actually proven, and I think this is already proven and published that the antibiotic resistance in our country is far away, from Western world. Now, I think there are certain unique problems that we have, which is not there in Western world, is about as Dr. Sujata pointed out about the misuse and misuse of antibiotics at the patient level. So most of the time most of our patients in our country, they use antibiotics for minor upper viral infections, upper respiratory viral infections, for thinking that it could be a bacterial infection, and antibacterials for 14 to 20 days. So there is no regulation from the authorities that whether these antibiotics should be prescribed just over the counter by the pharmacy. So these things are important, which are uniquely placed in our country, I think. And second is, I think that is at the level of primary care, and at the level of secondary and tertiary care, I would say that we don't have proper antibiotic stewardship policies. I think how many hospitals or how many academic centers do have an clear-cut policy for the use of antibiotics. So that is something which has to be done from our side. Specifically, what specific in every institute, I would say that this should have an antibiotic policy in hand, that in which infection, what duration, what antibiotic, what doses we should use. So that is something everybody has to look in, and these are the problems that we differ. These are the situations, or these are the issues we differ from Western world, that they have a better place system in where everything is defined, and and there is awareness by the people as well, that before taking any drug, they should consult at least a GP. But in our country, I don't know how many people consult a general physician also before taking an antibiotic. So I think these are the problems I can make out for our country as compared to West.
Akanksha, why are we at the epicenter of this pandemic? Why is it that if you have a Delhi belly, you're more likely to be resistant to the antibiotics than infections in the Western world? What are we doing wrong?
So I think, of course, Lingraj has already pointed some of it, that the fact that we as a population have just very easy access to all kinds of antibiotics over the counter. Prescription antibiotics are really not mandatory in India yet, which I think is a big, big issue. And probably the first hurdle and the first reason I would think so to the fact that we have so much of antibiotic resistance in our population. We would not get the over-the-counter drugs or antibiotics so easily in any country in the West. Having said that, it's not that the West also are not facing antibiotic resistance, but probably the pattern is different. They are also getting to see a lot of antifungal resistance and other kinds of things. But our population, I think, because we have this rampant use of antibiotics by people, by our livestock, it's probably there in a lot of things that we eat, because there is not much of regulation which happens. I think that is the main reason I would think that our population is, at the epicenter of this pandemic.
So the problem seems to be existent on many different levels. It's the prescribers, it's the end users, it's the lack of regulation from the government side. So in the Western world, if someone had to get an antibiotic, the prescription would have to be well justified. First of all, you wouldn't get an antibiotic without a prescription. Also, are we also sort of not very stringent about our clinical protocols now? Once patient has cough or cold, sometimes the patients or even the medical practitioners always seem to put them on an antibiotic without really asking ourselves, is this a bacterial infection or is this a viral infection? Now, how many of our users who have tuned in this afternoon, we have to ask ourselves, how many times have I taken azithromycin by myself when I have developed a cold? So, are our clinical protocols not that stringent?
Yes, definitely. Even as medical professionals, I think the urge to prescribe antibiotics for everything and every small thing is also very high. Having said that, if I just have to look at it in the last 8 to 10 years, I still feel that there is some amount of education which has come in, even at the level of the general practitioner and pediatrician. Initially, I think 9-10 years back, the ease with which antibiotics were prescribed for every upper respiratory infection was very, very high. It has definitely come down, but yes, the urge to prescribe an antibiotic for every small thing is something which has contributed to this.
Lingaraj, is there a fear of missing out? Is there a FOMO that, if you don't prescribe antibiotics to your patient, and things do go wrong, then you would be blamed? Or, in a competitive environment like India, the urge of the physicians and the medical practitioners to please their patients is intense and enormous. Is there a fear which is driving this sort of irrational use of antibiotics?
I think I would not say fear. I would say this is like, over treatment, I would say. No, the kind of situation that arises, when you have a situation where you are not sure and you don't want to investigate further, specifically in a situation you don't have good facilities to investigate further, people typically prescribe antibiotics thinking that it is infection. And I think one of the cause why the use is so rampant. And now in situations, and I want to also tell the viewers that most common presentation where infection is there is fever, and fever is not the only because of infection. We have many other causes of fever as well. And most commonly we prescribe antibiotics in situation of fever, and subsequently we have to come down and kind of evaluate the patient and decide that whether it is really an infection which requires the continuation of antibiotic, or you should just stop it, that whatever provisionally or empirically we have started, I think that we have to stop and move ahead. So I think that is one thing I would say, over treatment. And to please the patients, sometimes, yes, when specifically in COVID pandemic, I have seen quite a few prescriptions, printed prescriptions by many, physicians about, for any mild, moderate COVID, we have, a list of drugs to be taken if you have a mild COVID and what is the duration, and these all are printed. So I think how many number of patients would have taken that drugs and whether that has increased the antibiotic resistance. Nobody knows that. So that is something which is not going to be counted or accounted, because this problem, the magnitude of this problem can never be kind of gauged by any route. No, it is like a problem that is there, and we are all aware, but difficult to kind of give a number and how much. I think whatever estimation we make, I think it will be more than that. No?
So you talked about clinical situations like patient comes in with fever and we are giving antibiotics without really asking ourselves, is this an infection? If yes, is this a bacterial infection? If yes, again, is the antibiotic that we are giving necessary? Is it going to cover that particular bacteria? What are some of the other common clinical scenarios that you would like to tell our viewers in which antibiotics are commonly abused? I talked about the common cold, and most of it, 90% of common cold is actually viral, and we are prescribing an antibacterial agent like azithromycin. What are some of the clinical situations in your experience and in your clinical practice wherein antibiotics could have been avoided, but yet there seems to be an overprescription, or just it's just the way we've been doing things, maybe?
Yeah. So the first thing you pointed out is viral infection. Common cough and common cold, 99% are viral. There is very few which are super bacterial infection. Second common is dengue fever. Dengue fever is such a common infection in our country, and wherever you go and you see, the prescription always have an antibiotic. So patients of dengue fever will have fever, and dengue is a viral infection, and same is true for COVID. Now malaria. So malaria has anti-malarial drugs. So malarial infection do not need an antibiotic. So there again you see an antibiotic use. So if you see the magnitude of problem of dengue, malaria, all viral infection is so huge in our country, and if you add antibiotic to all these three infections, I think that will increase the burden phenomenally, the use of antibiotics.
Absolutely. I'm really glad you pointed out dengue. Asymptomatic urinary infections, patient has a urine culture which is positive, but truly is not symptomatic. So in these sort of situations, as long as the patient is not going in for any instrumentation or surgery, or let's say, he's colonized by a fungal organism and he's not neutropenic, or he's not an immediate post-renal transplant patient, these are not the kind of situations which need antimicrobials. What about COVID? You mentioned COVID. At what point would you really use antibiotics in a COVID patient? And I'm assuming we're talking about hospitalized patients, because outpatient COVID patients, who are there isolated at home, really don't need antibiotics. They don't need azithromycin. Azithromycin is an antibacterial agent. It has been proven to not have much of a role in COVID. So at what point would you give your COVID patients antibiotics?
Yeah, I think in COVID patients, specifically who are hospitalized, now there is ample of evidence which says that only 10% of patients who are severe COVID have secondary bacterial infection proven. So that means almost 70 to 80% of the patients do not have an super infection. So I think the situation where I would prefer an antibiotic for a COVID patient is when they have fever, along with that a proven infection in a CT scan or an X-ray for that matter, if CT scan is not possible, along with some proof of infection in the blood. And there is any hemodynamic compromise, in the sense that the patient have low BP, low saturation. I think that is one area where I would tend to give an antibiotic for a patient. And if I prove in 48 hours that there is no evidence of infection by whatever method, then I would probably drop down or de-escalate the antibiotic and continue with whatever supportive care I would take. And one more thing I wanted to add about this urinary tract infection. I have seen people who come to the to the OPD, and if you ask them, they have taken some antibiotic, and this UTI thing is so common in our country, and people know E. coli. If you can, there are certain patients who say that I had E. coli 1 year back, so for that I taken what E. coli. So no, I have E. coli. I have urine problem. Then you will get to know that the doctor has told them that they have E. coli. So now E. coli is a bacteria, and that can be a colonizer in a female. So whether they had symptoms of urinary infection, whether they have all the symptoms that they should have, so they're not aware. They think that, okay, there is a bacteria, so let's treat it. So that's how is the use of, I would say, abuse of antibiotic in our country.
Absolutely. One other common thing that keeps happening with patients, and you mentioned urinary tract infections, is that they keep getting routine urine analysis done. It keeps showing pus cells. Pus cells does not equal to a urinary tract infection. It just shows you an inflammatory reaction there in the urine. Now, whether or not there are organisms, and even if there are organisms, whether or not the patient needs to be treated really are the questions that we need to ask ourselves before prescribing. And these are the questions that patients also need to ask themselves and ask their doctors. So you mentioned that not more than 10% of COVID patients actually have a superadded bacterial infection. So by that, we should not be giving antibiotics to more than 10 to 20% of our admitted COVID patients. So in reality, how many of them are actually getting antibiotics in the COVID ward?
I think it is, when the patient usually they present to us when they are sick looking, most of them get. But after 48 hours, when you are sure that this is not a bacterial infection or a super proven infection, I think most of them we are able to de-escalate. Some we have to continue thinking that when you are very sick, you have got some infection proven in the lung or in the blood, and there you need to continue the antibiotics. But if you see initially when the patients are sick enough, we always add antibiotics thinking when we have not proven yet. But I think after you have evaluated the patient for 48 hours, there is enough evidence now to say that you should de-escalate the patient.
So I think Lingaraj, your voice was your volume was a little low. If you can just quickly repeat what you said, in a sentence.
Yeah. So what I say is that when the patients present to us, they are sick looking, they have high spiking fever, they have hemodynamic compromise. Most of the patients get antibiotic along with the other supportive care. But after 48 hours, when you have evaluated the patient and you have found there is no proven evidence of infection, I think that is the right time to de-escalate the antibiotic and continue the rest of the medicine.
Right. Akanksha, any specific situations in pediatric patients, and I'm not talking only about pediatric oncology patients, but in pediatric patients in general, wherein, there are situations wherein actually kids who don't need antibiotics, end up being prescribed antibiotics?
So, I mean, in pediatric patients, the first example that you gave of an upper respiratory infection, which is 9 times out of 10 a viral, so we get that very often in the children. They will get repeated upper respiratory tract infections. They will get something which is called a bronchiolitis, which is a viral triggered, kind of a situation where antibiotics are actually not warranted at all. So respiratory infections are very common in children, and a lot of times they are treated with antibiotics by the practitioners. So that, I think, is one big subset in children where they keep on getting repeated antibiotics. Apart from dengue and malaria, which pointed out, we don't see urinary tract infections so common. But yeah, respiratory infections would definitely top the list.
Is there a divide in the public sector versus the private sector, or in academic institutes or teaching institutes versus non-academic institutes, both in terms of how much of adherence there is to protocols, how much of evidence-based medicine is practiced, and also the kind of patient population, the affordability of patients, how demanding the patients are? So because of the fact that all these differences do exist, is there a difference in the problem of, or the magnitude of this problem in the public sector versus private sector? I mean, no one better than you to answer this question, someone who works in a prestigious academic center.
So yes, probably there is some difference. I wouldn't say that there is a huge difference, but yes, there is some difference. In the private sector, I think sometimes you have parents who are very demanding. They really obviously are very worried if the child is having high grade spiking fevers with some cough, and a lot of times they do get prescribed antibiotics which are not required at that time point. Having said that, whether it's a public institution or even some well-established private institution, if like what we spoke about earlier, there are certain departments and institutions which have an antibiotic policy already in place. So that is very important. There are many private sector institutions which already have that, and so they adhere to those protocols quite strictly. But yes, if I just have to say offhand, in the private sector, yes, probably a lot of the institutes do not have this kind of an antibiotic policy. So we get to see this maybe a little lesser in the academic institutions as compared to the private sector.
Prayag, can I just intervene? There are quite a few questions on the chat box.
Yes,
so
absolutely.
So just keep that in mind, while we are discussing with the panelists. we may have to answer those questions from the audience.
Yes. What I'll do is probably I will leave the last 5 or 7 minutes for that, if that's okay.
Okay. Yeah.
So, Dr. Sujata, I think Lingaraj mentioned the word antimicrobial stewardship. So, for the benefit of our audience, would you like to elaborate on what is an antimicrobial stewardship, and how many hospitals are actually implementing it? What are the components, and how can we implement this in our setups? Dr. Sujata?
The question is for?
No, I said that, Lingaraj mentioned the term antimicrobial stewardship.
Yes.
Can you elaborate
So,
on this concept?
Yes, the antimicrobial stewardship is a kind of program which leads to stepwise and appropriate dosing and selection of antibiotics that leads to reduction in the development of resistance in the hospital setting for the patients. So there is a structured antibiotic policy which is in the antibiotic stewardship program, which leads to the framing a set protocol for a subtype of infection, that which antibiotic has to be started as a empirical drug for this subtype of infection. Stewardship also involves education among various healthcare professionals and the various measures taken by the reporting team, the measures taken by the clinicians and the pharmacist, everybody. That is a teamwork at a hospital setting that leads to appropriate selection of antibiotic and appropriate prescribing of antibiotics, that leads to a reduction in the antimicrobial resistance in the hospitals. So it starts basically at all the ends, from prescribing to detection of sensitivity and resistance in the lab to consumption. It involves all the parameters of an hospital.
Lingaraj, are we doing enough as far as stewardship practices are concerned?
So I think I will just add a few points of what Dr. Sujata has told. So one is making a guideline, and stewardship is one way ahead, that how we are implementing it and what is the audit of that. So that involves the stewardship. When you say an antibiotic policy, we have a team of people involving a clinician, a microbiologist, a surgeon. So there will be a team, and then how it is implemented, the reporting of that, like how many violations of those antibiotic policy have been made and what we have done for that, and what we have done subsequently, what corrective measures were taken. So this is a continuous process. So when you make a guideline and how it is implemented and what % of people are using it, and whether that use is consistent, and whether there's any break or any kind of violation of that use, so that involves antibiotic stewardship. I think that is something which every hospital should have. I would say not. I would say every hospital, not barring academic or private sector. Every hospital should have, and that will give an audit of what they have done in last 6 months and what changes they have made, and whether that has resulted in lesser incidence of antibiotics. So I think this is more important, as an rather than giving a rough estimation. We should have an objective way of assessment of our use of antibiotic and its implication in our patients.
Absolutely. So as you mentioned, auditing is one key component of it. One is information gathering. So how are our antimicrobial practices? What are our protocols? How much are we adhering to it? And then sort of auditing the practices, reaching out to the clinicians at the end of specific periods of time. So this needs support from various levels, from the management, from the clinicians. So antimicrobial stewardship is a multifaceted program. Akanksha, your experience with antimicrobial stewardships, now you've worked both in the corporate sector as well as in an academic environment. Your personal experience with the antimicrobial stewardship programs, if they did exist in these institutes where you've worked at?
Yeah, no. So Parikshit, like I said, barring whether it's a corporate sector hospital or an academic institute, the places where I have worked, at least, yes, they did have an antimicrobial stewardship program in place, and which probably is the only way forward to tackle this problem, apart from, like we talked about, educating the general public, because until unless we we have an audit and a data of what is actually the practice which is happening in the hospital, only then can you formulate the correct antibiotic policy. Only then you can give a feedback to the physicians or the clinicians that, this is probably not the way we should be doing things. So I think wherever there has been a good antibiotic policy and stewardship in place, there have been, changes which have been always there in the positive direction, and are trying to control this. So that is something which I think every hospital, whether small or big, needs to have at this time and point.
So Lingaraj, on a government level, is there more that needs to be done as far as enforcing antimicrobial stewardships are concerned, sort of tying it up with some sort of compensation or numbers? And, as we head towards an insurance driven culture, or at least an increasing insurance driven culture like the Western world, would it help us in terms of antimicrobial stewardships? Because some of these practices would be questioned.
I think no, in our country, every policy you make, there has to be some incentive, then only that is going to work. So antibiotic stewardship definitely has to be pushed in all government institutes and also in private. And there should be some kind of incentive for those people who can show that their antibiotic resistance pattern is the best in the country. Maybe there should be that will be the way to kind of help in implementing. Without incentive, just making a policy and in every institute and pushing it may not help. I think that has to be incentivized now by the regulators.
Absolutely. Dr. Sujata, your take on this. Why are we not able to translate antimicrobial stewardship practices which are laid down on paper into actual reduction of antimicrobial resistance in the wards?
Very correctly said that all the parameters related to antimicrobial stewardship are on the papers at most of the institutes, but the implementation level does not matches that the data which we have collected. One thing is we are not able to convince this matter to the bedside that whatever is written in the paper, the policy has to be followed strictly. Otherwise, the result which we are going to see is disastrous. The barrier between the calculation of the resistance and the convincing to the bedside is has not been crossed basically. So there is a one AMR project also going on by the AIMS and CMC Vellore. So they are collecting the data from all the hospitals that what kind of resistance
I think, Dr.
is
Sujata,
there,
we
how
are
much
unable to hear
pattern
you.
of carbapenem and how much for the lower. They are collecting all the data, but the it will take some time, way larger. Sorry,
No, I'm sorry, we were unable to hear you for a brief while in
I
between.
didn't hear. I'm not able to hear actually.
Yeah.
What did you
Okay.
say?
Maybe there were some technical issues, but what Dr. Sujata meant to say was that, there needs to be a collaborative data, pool data, which will really tell us what's going on in the community. And for us to be really able to translate this into clinical practices, as we've been saying, there needs to be auditing and there needs to be action. So there really needs to be also a keen interest from the management about all these aspects. Lingaraj, any suggestions about how we can actually make stewardship programs work in the country? You mentioned incentivizing was one way of doing it.
As I said, Parikshit, so I think everybody is aware. I think there has to be some push from the management, from the government regulators. But as I said, the only way to work it in ground is to incentivize it. There should be some auditing across various hospitals and to see the pattern of resistance, maybe over a period of time, that whether that particular hospital is having a lot of MDRs, and what is the use of antibiotics, what is the number of patients they have admitted, and how many kinds of antibiotics they were used in those patients. So I think that somehow some kind of auditing has to be done periodically, and only making a stewardship in every hospital will not end here. So we have a lot of things to do to tackle this problem, in the country.
Akanksha, do you think we are not training residents and fellows enough in antimicrobial stewardship? A lot of them, when they actually go out and practice in the real world, don't really know how to implement an antimicrobial stewardship program. I remember during my infectious disease training in the US, we used to get posted on the antimicrobial stewardship rotation for about 3 months, wherein we would carry the antimicrobial pager and then work with stewardship experts. So are we lacking that sort of an approach in India, wherein we are not training people, because it's the blind leading the blind as far as antimicrobial stewardship programs are concerned?
Yeah, I think, yeah, you're right, Parikshit. Probably that's because I think we are still kind of finding our feet in terms of every institute is, I think, just still kind of in the process of getting the antibiotic stewardship program established in their hospital. So I think we are still at that stage where we are just kind of trying to get that in place. But yes, you're correct. Though the fellows and the residents and the the DM students all do get training in terms of, they do get lectures which they attend on all these things, but there is no structured training about this particular aspect, which is lacking. Yes.
Absolutely. Great. So we've had a wonderful discussion. We have talked about various aspects of antimicrobial resistance, and coming from a microbiologist and coming from two clinicians who mainly handle immunocompromised patients. We talked about what is antimicrobial resistance. Then we also talked about some of the problems which are unique to our setup, that why are we seeing such high numbers of antimicrobial resistance. Then we talked about some of the solutions, how we can train young minds, when they are in a moldable stage, how we can implement antimicrobial stewardship programs. We also described some common situations in which we are seeing an abuse of antibiotics, and how, as a patient as well as a doctor or as a clinician, we need to be mindful of these situations. So let me take a few questions from our audience this evening. So let me start with our microbiologist, Dr. Sujata. We have a question: are superbugs easily transmissible? So which means that kind of resistant bacterial infection spread from one patient to the other in a hospital environment?
Yes, there are various ways in which a superbug can transmit very easily. So that the patient can transmit it to another patient by the contact, by aerosol generation, that is same equipment, or the use of the same bed sheet, linen, clothes, by use of the same utensils. Also in hospital setting, these are the ways by which a bug can be transmitted.
Yeah, so again, I'm afraid there were some technical issues, but what Dr. Sujata meant was that superbugs are absolutely transmissible, and that is where the infection control practices in the hospital come into play. So there are a lot of cases wherein there are different ways by which these superbugs can acquire resistance, and in fact, in the hospital environment, one resistant bug can actually make the adjoining bug, which is not resistant, become resistant. So these are some of the ways, and there are different ways. So there are plasmid mediated resistance mechanisms, or there are conjugated resistance mechanisms, or there are transmissible resistance mechanisms. So that is why when we do find patients with resistant infections, we ideally need to practice infection control on a higher scale. We need to isolate them. We need to do things which are right for them. Lingaraj, are we not doing enough to isolate patients with resistant infections?
Yeah,
Of the
so
infection control practices?
that is something which we can do for our patients, provided your infections or your superbugs are lesser in number. When you have a situation where your ward is many patients have superbugs, then it becomes a challenge. So I think that is also one area where the containment of an infection is important. So in a hospital setting where you have a ward where there is an outbreak and there is a patient who has an MDR or resistant bug, I think first thing is you have a separate facility of isolating those patients. You should do that, and that can contain it, and it kind of prevent the spread of infection to other immunocompromised patients. As you rightly said that it can make other bugs and all which are sensitive also resistance by various mechanisms. So isolation is one way that can be done.
Absolutely. A lot of our listeners and on audience actually are bothered by the fact that we get antimicrobials so easily over the counter in India. Akanksha, what can we do about this problem?
So I think it is something, a regulatory issue. Probably it is something which I think the government can do something about. One thing is there has to be tighter control, that the pharmacist should not be able to actually dispense any medication without, or at least an antibiotic without a prescription, which is not really in place. So I think probably, it has to be a regulatory kind of a decision which has to come.
Absolutely. Can we do something to educate the media to write more about it?
Yeah,
Someone
definitely.
wants to know.
Yes. I think that is something which we are not talking about enough. Like we talked about, we're talking about this in the medical community, but this has to probably be spread out to the general public that this is actually a pandemic of bigger proportions than the COVID, which has been happening for the last 2 years. And I think that is one very good way of educating people through the media.
Absolutely. So I think we've taken up most of the questions that I at least see in the chat box here. Vandana ma'am, please feel free to ask any questions that you have which I don't see on the chat box here.
Well, no, I think most of them have been taken care of, but one thing is that, would you say that AMR is in one patient today has a societal impact?
Absolutely. I'll take the liberty to answer that question. So absolutely, antimicrobial resistance in one patient has a societal impact because, as I think Akanksha touched on this briefly, what antimicrobial resistance does is that, it interferes with clinical outcomes, which means that not only is there more morbidity and mortality associated with it, but it means longer hospital stays, more cost of healthcare going up, as well as, the spread of antimicrobial resistance. So it's not a problem which remains restricted to one patient. So again, inter-hospital transfer of some of the antibiotic resistance mechanisms. So it's not a problem which is going to be isolated. It's not a patient who is coming in with a fracture. It's definitely a problem that is going to have a societal impact. So this is not an isolated problem by any stretch of the imagination.
Also, when I think Dr. Sujata was mentioning that the infection happens in the wards and the hospitals and all that, and it can lead to a larger infection. So how is that infection different from the COVID thing? Because in COVID also we are seeing the same thing, that infections are spreading from one person to the other, right? So is there a difference, or is it that COVID has magnified this cross infection spreading?
No, so if you talk about spread of infection and spread of resistance, these are two different things. So when we talk about spread of infection, as we are seeing in COVID, these are, there are different airborne mechanisms or droplet mechanisms. So for example, if you are in contact with a COVID patient and if he coughs or sneezes, then you would inhale the COVID organisms, and that is how you will get COVID. But what we are seeing with antimicrobial or what we are seeing with resistant organisms is that they can actually be transmitted from one person to the other, one patient to the other physically. So for example, if I, let's say, examine a patient who has a resistant infection and use the same stethoscope or use the same white coat and see someone on who is admitted on the adjoining bed, then I may physically transfer the resistant infection from one patient to the other. The other part of this problem is that resistant bugs can make sensitive bugs resistant. So resistance is a phenomenon which sort of thrives on survival of the fittest. So if I have a particular ABC bacteria which are resistant, and just in the adjoining patient they are actually susceptible, then those adjoining bugs can acquire resistance. So there are different mechanisms, as I talked about, there are plasmid mediated mechanisms, or it is called conjugated resistance. So there are different mechanisms in which the adjoining bacteria which are existent in the hospital environment actually can become resistant. Also, if you are using a particular antibiotic to a large extent in the hospital, if within that environment, the bacteria may not be susceptible to that antibiotic. And that is how local islands of resistance differ. And that's why there is a lot of discrepancy as well. And we always keep saying that we must know our local trends of resistance and patterns of resistance, because all these local factors are very different at each place.
So Dr. Prag, you have made me think, like, suppose I'm a patient and you come to examine me. Can I have the right to say that I want you to clean up your stethoscope before you examine me, or will that be accepted? Because, with the population that we have and the crowd that we have, are we really doing enough? I mean, I know you're doing enough, but from the patient's point of view.
Absolutely. I don't think anyone as a clinician or as a doctor, regardless of his stature, should be offended by someone reminding him of hand washing, or someone reminding him of the fact that he doesn't have a clean white coat or a clean stethoscope. I mean, a polite reminder would probably be better, but I don't think anyone should be offended by that. We have infection control nurses in the wards, who remind consultants about hand washing. To be honest with you, some of them don't take the suggestions that well, but as medical practitioners, we absolutely need to be cognizant of the fact that we ourselves can be transmitters of resistance. So as a patient, you have a full right to remind your doctor politely about the fact that he needs to be a little bit better about his infection control practices.
So Vandaji, can I just say something here?
Yeah, please, Dr. Khatri.
So, what we do in ACTREC is each patient has a stethoscope at the bedside. And when that patient gets discharged, that stethoscope is cleaned. So the doctors don't carry the stethoscope. And that way, you are not taking the same stethoscope from one room to the other with the doctor. And I'm not sure how much it makes a difference, but certainly it's a small step in probably decreasing the transmission of infections through what we call fomites, that is inanimate objects. Hand washing certainly is the most important, but these little steps may also help.
Yeah. So, we provide the infection control kit to the children in Tata Memorial Hospital. And we were, little surprised when we were told to keep individual torches and individual thermometers in the kits. And now when I'm hearing all this, it makes sense that, the torch that the doctor is using to examine a patient, if it belongs to that particular patient, then the chances of the bugs being transferred from one to the other become less. So it's a great insight into the whole thing, I think. And next time we won't regret putting the torch in the infection control kit or the thermometer. So that's good. Thank you very much, Dr. Prag, Dr. Khatri, Dr. Sujata, Dr. Lingraj, and Dr. Akanksha. I think it's been one of the most informative webinar that I have attended, because I had little knowledge of it. And, I must say that I'm guilty of popping an antibiotic if my temperature doesn't come down, and, I have to go somewhere and I need to do something. And since I have the standard names, I go and buy it over the counter, and then 5 days of that antibiotic, and I feel I'm fine. And now I understand that it can cause a lot of problems in the long run. And I'm sure many of us who heard this today would feel the same. So now the first learning is not to have an antibiotic unless prescribed by the doctor, and not to buy it. But these days also, with teleconsultation happening, a lot of doctors do give out the names on the phone. So you don't have a physical prescription, and you go into a shop and you buy those things. So if the regulations do come up, then we need to see how this would be taken care of. How the medical shop or the pharmacy will not sell the antibiotic without a physical doctor's certificate, a prescription. So you want to say something about that, because this is a thing which has come up, and I think teleconsultant is going to pick up in a big way, because people have found the ease of doing it, not going to the doctor physically.
Yes. So, I think with telemedicine, and you're right, telemedicine has picked up tremendously during the pandemic. But, the ideal way of doing a teleconsult is not just to send WhatsApp messages to that patient. It really involves a video consult or an audio consult, followed by some sort of a written feedback to the patient in terms of, what we discussed, what the plan is, and the prescription. So again, if I'm seeing a patient over a video consult, then once I disconnect, it is actually ideal to sort of email the prescriptions to him, or email a brief summary or a note of what we have discussed, similar to what we do for physical encounters. At the end of the physical encounter in the OPD, we do give the patient a summary of what we have discussed, what the plan is, what the diagnosis is, what are the sort of investigations we want to do. So that would be ideal. And again, this is an evolving field, so there is a teleconsult telemedicine Society of India, which definitely should take up these things. I mean, things during the pandemic were different. So during the pandemic, the access and ease of doing all these things were also different. But this is the kind of direction we need to move forward.
Yeah. So Dr. Khatri, may I request you to kindly help us close the meeting with your guidance about some of the things that all the doctors have so wisely told us.
Firstly, I'll agree with you that this was a very useful and informative, panel discussion. And I thank Parikshit for making it so interesting with the three panelists, Akanksha, Lingaraj, and Sujata. I think it's very, very important that we take this seriously, the antimicrobial resistance. As Parikshit said in his opening remarks, that India seems to be the capital of the world when it comes to antimicrobial resistance. And he's very right to say that if South Asian came to a hospital in West, that person looks as an alien. And I have first-hand information because when I was in Bristol in UK for my transplant training, we had one patient who underwent transplant in India and then had a second transplant in Bristol. And I know how it became a bit uncomfortable because everyone looked that this person would be transmitting the newly found NDM, the New Delhi metalloproteinase resistance, the Delhi bug, which was scoffed at by us when it came in Lancet many years back. So I think that's very, very true. So I don't know how we will overcome this. It's a huge, the problem is that, we may have ideas, we may have SOPs laid down, we may have plans made, national, local plans, but the implementation on the ground is very, very difficult. And we clinicians are usually the one to be faulted. The microbiologists may say that you have to do it this way, but the clinicians are so resistant to be advised that they think that they have the mind of their own, and I'm guilty of that. I think I know more than the microbiologist, and I wouldn't listen to them because I think I know more than them. And this is all pervasive in small ways, big ways, both in our country, but also in other countries. So I don't know. I have no solutions for this, but certainly this needs to be spoken more at each level and given more importance than what we are doing in the country right now. This certainly is, it is, I think it is more serious than COVID right now, the antimicrobial resistance.
Yeah. So Dr. Khatri, though I said I'll give you the last word, but I must say one thing to all our doctors and anybody, any of you who's talking to the press, if you can put one or two lines about AMRs, then it will become like a constant education to them. And also if there's an article that they are writing, then they would write about it and people would want to know more about what is the type, what do you mean by AMR and how do we carry on and what do we do. So I think that will be a great help to the community at large from your side, because whenever you are talking, whenever you are writing, whenever you're doing something, a little one or two lines about it would really go a long way in education of all of us who are laymen in the language.
Yes.
With that request, thank you once again. And I know we've gone over time, but I'm sure it was worth every minute that we've spent together. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.